Welcome back again. This time we'll be discussing antipsychotic drug toxicity, corresponding to Chapter 67 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to name the receptor that antipsychotic drugs block to produce their therapeutic effect, and then also name at least 3 other receptors they also block which are responsible for some side effects. Describe the various extrapyramidal adverse effects that can occur with antipsychotic drugs and how we treat some of them, and to list the clinical features of NMS, the neuroleptic malignant syndrome, and be able to compare and contrast it with serotonin syndrome. So we're talking about antipsychotic drugs, which immediately raises the question of, well, what is psychosis? Like the figure in the previous slide, if you believe there are little green aliens controlling the thoughts in your head, that delusion is probably a part of your psychosis. Psychosis is a failure of reality testing, where the person can't properly assess whether what they are thinking or perceiving is real or not, like the voices they hear in their head or visual hallucinations. The cat drawings here were all made by the artist Louis Wayne, who was known to have mental health issues, likely schizophrenia. He was famous for his art of mostly comic anthropomorphized cats, and some have suggested this series of increasingly bizarre drawings could reflect the progression of psychosis. But it may also have just been artistic exercises of color and form, especially since the chronological order of these works is not well established, but I think it's a cool story and beautiful art anyway. This slide shows an oversimplification of the mechanism of action of antipsychotic drugs. They work by blocking dopamine 2 receptors. There are several dopamine-dependent neural pathways, and the desired therapeutic effects come from dopamine blockade of the mesolimbic and mesocortical pathways. Blocking the tuberoinfundibular pathway is responsible for potential side effects relating to increased prolactin levels, while extrapyramidal motor side effects occur due to dopamine blockade in the nigrostriatal pathway. If that weren't enough, the antipsychotics are very promiscuous, and they block several other receptors in addition to dopamine. They can block muscarinic cholinergic receptors, alpha-adrenergic receptors, and histamine receptors, and the newer atypical antipsychotic drugs, those whose generic drug names end with pene or done, block serotonin. Many of the side effects of antipsychotic drugs, even at therapeutic dosing, are related to blockade of those other receptors. Histamine blockade interferes with neurocircuitry promoting alertness, resulting in sedation. Muscarinic acetylcholine receptor blockade produces antimuscarinic effects like dilated pupils, dry mouth, and other features of an anticholinergic toxidrome. Alpha-adrenergic blockade in therapeutic doses may result in orthostatic hypotension, lightheadedness when standing up, and with overdose can even cause worse hypotension. That last slide might have looked very familiar if you've already seen the video about cyclic antidepressants. The adverse effects profiles and also the chemical structures of the antipsychotics are similar to those of the cyclic antidepressants, so that the previous slide is what they have in common. Antipsychotics can also induce extrapyramidal effects, which we'll get to very soon, while the cyclic antidepressants instead cause sodium channel blockade. Antipsychotics might also prolong the QT interval, which can place patients at risk of developing torsade de pointe, which you've already heard a bit more about if you've seen the previous video about magnesium as a potential treatment for drug-induced torsade. Okay, back to those extrapyramidal effects. In the brain, in the medulla, there are some structures that reminded historical anatomists of pyramids, and the motor pathways running through them were called the pyramidal tracts. But it was later discovered that there are additional motor tracts that didn't run through those pyramids, and those are the extrapyramidal tracts. Dopamine blockade can affect motor neurotransmission through the extrapyramidal tracts, and those adverse effects are extrapyramidal effects. I'm noting the concept of extrapyramidal with a figure that has not one but 2 pyramids. There's an extrapyramid. There are 4 categories of extrapyramidal effects, and the green arrow here is showing them from earlier onset after drug exposure to later onset following exposure. I'm going to be showing you videos of 3 out of these 4 effects because a video illustrates this a lot better than any number of words or static images. Extrapyramidal effects occur from upsetting the dopaminergic to cholinergic balance in the basal ganglia necessary for normal motor control. If you block the dopaminergic tone, then the cholinergic tone predominates. And the general way to then restore the balance is to also block the cholinergic tone by giving anticholinergic drugs, such as benztropine or diphenhydramine. So first I'm going to show you 2 short videos of patients with acute dystonia from dopamine-blocking drugs. And I'm showing these first because acute dystonia is something that can occur very shortly after administration of dopamine blockers, including antipsychotic drugs, often within minutes to hours. Thus, the acute dystonia can be considered an acute toxicity of antipsychotic drugs. The first patient we'll see had been given a nausea medication with dopamine blocking effects, and the second had taken their routinely prescribed antipsychotic drug.
So, when did you start having trouble talking?
Critical?
Early this morning? And did you take any drugs? Other than your prescribed drugs? Count to 10 for me.
1, 2, 3, 4, 5.
Okay, that's good.
Yeah. Wait.
I do. I feel better. I feel like I can talk and say what I want to say now.
All right. Cool.
I feel better. I am glad I came to see you all. Hey, glad to see you all here at MCG.
Count to 10 for me now.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
All right.
1, 2, 3, 4, 5, 6, 8.
Now he's hamming it up. Okay.
Yeah. I feel better now. I feel better.
Now your voice isn't perfect, but is this how you normally talk?
No.
Not yet.
But the doctor said, give me some Benadryl, and the doctor knew exactly what the purpose was.
Now, are you talking back to normal for you? Is this how you talk?
Yeah.
Okay, all right. So you had some traumatic brain injury sometime in the past, is that right?
They cut my brain.
Okay, and so but you have some psychiatric issues too that you're being treated for.
I be having I be having flashbacks.
Flashbacks. You're very kind to the rest of us, you know.
You're
That's thoughtful.
very kind too, and I appreciate you for helping me.
All right, you're welcome. You're welcome.
Next, we're going to see a very short video of a patient with akathisia, which is this internal sensation of unease, restlessness, a feeling like you need to move or just get out of there. This can also occur fairly quickly after being given antipsychotics. I believe that cases of akathisia are probably underrecognized and underreported. If the patient is not too sick and they say they need to leave, then we let them leave and didn't even know they had akathisia. But if you know what you're looking for, instances of akathisia are pretty common. The term tardive dyskinesia literally means a delayed onset motor abnormality. While this is a drug-induced condition, it's not really the kind of acute toxic effect we're focusing on in this series, since it usually takes many weeks, months, or even years of drug exposure for it to develop.
This 76-year-old woman has a 2-year history of tardive orofacial stereotypies related to an 8-year treatment of chronic nausea with phenothiazines.
How old are you?
77.
And what is it that's bothering you the most?
My mouth.
How long have you had the problems with your mouth?
Well, I guess about a year and a half.
How long?
About a year and a half.
Okay.
And the last kind of dopamine antagonist-related toxicity to cover is NMS, the neuroleptic malignant syndrome. For reasons we're not going to get into, the antipsychotics are also called neuroleptics, and the malignant part means that this is a dangerous condition. Very dangerous, yes, but at least it's not common. Back in the 1960s, NMS was reported in a few % of patients given antipsychotic drugs, while in more recent times the incidence is just a fraction of a %, which in part is probably related to the increasing use of newer, atypical antipsychotic drugs, which have a more favorable adverse effects profile. Neuroleptic malignant syndrome is characterized by 4 features: hyperthermia, altered mental status, autonomic instability, that is, concerningly abnormal vital signs, and muscular rigidity. There are different ways to have muscle rigidity, and with NMS, patients are described as having lead pipe rigidity. If you try to bend their arms or legs, it's like trying to bend a lead pipe, which has firm and constant resistance. There are other conditions, such as Parkinson's disease, where the muscle resistance drops off intermittently or spastically, and that's not like a lead pipe. There's a variety of treatments used for NMS, including IV hydration, cooling measures, sedation if needed, and using some otherwise very infrequent antidotes like bromocriptine and dantrolene. The description I just gave of NMS you probably noted is very similar to that for serotonin syndrome. Whenever you might be thinking of one of them, you probably need to keep the other on your differential diagnosis, your list of possible diagnoses you're still trying to determine that the patient might have. Looking at the NMS tetrad, we see that, actually, serotonin syndrome can have all 4 of those findings of hyperthermia, altered mental status, autonomic instability, and muscular rigidity. However, the kind of muscle rigidity in serotonin syndrome is different. If you're only looking at a single point in time at what signs and symptoms the patient has, NMS and serotonin syndrome are very similar, essentially indistinguishable. But we can differentiate them pretty effectively by a few points in the patient's history. If the patient was exposed to a new drug, including through an overdose, and they developed these signs and symptoms right away, then that's serotonin syndrome. NMS takes days to weeks to develop, much slower onset. The patients with NMS are stiff and have decreased movement, while serotonin syndrome increases your muscle tone but also abnormally increases muscular reflexes to the point the patient is very twitchy with hyperreflexia and clonus. And also you can ask, what kind of drug was the patient exposed to? If the patient is taking pro-serotonergic drugs and not antipsychotics, then it's probably serotonin syndrome. If they're not on serotonergic agents, or at least no new serotonergic agents, and they have recent exposure to dopamine blocking drugs, then it's probably NMS. This is a lot to say about a very rare potential complication. While I think about NMS in patients I see in the emergency department maybe a couple times a year, I've yet to diagnose a new case myself. But I see people with varying degrees of serotonin syndrome several times a year. And that's all I've got to say about antipsychotic toxicity for now. I'll be seeing you around.